डॉक्टर सागर जॉईन नाही झाले का? Unmute.
He said he's joining in 2 minutes.
No, I have joined.
Okay, welcome, sir.
Grivita ma'am, start it.
Okay. Good evening, everyone. Today, on the auspicious occasion of Ashadi Ekadashi, it gives me an immense pleasure to present to you yet another important session in Wednesday Wisdom on childhood asthma. Together, we can breathe easier. Asthma awareness is the key to healthier future. On the outskirts, I welcome Dr. Ram Gopal sir, President Maha-AP, for his few words of wisdom.
Okay, thank you, Grevita. Good evening, friends, and happy Asadi Ekadasi. I think you people had something and then you have joined. Friends, as the topic in the Wednesday Wisdom, this is the monsoon season going on. So we had decided that, okay, we'll take something which is related to the respiratory system. So as our women's committee decided to have a topic of asthma in children. Now I welcome to the today's experts, Dr. Barnali Bhattacharya. She is a pulmonologist from Pune, and Dr. Sagar Varankar from New Bombay. New Bombay is our own branch. So welcome, Dr. Sagar. Now, friends, actually today's presenters are also experts. So today's session would be, or I can say it would be a tufani session, because experts presenting the case plus we have a talented Dr. Sagar and Barnali madam giving their opinion. So asthma we divided into 5 parts. One was asthma below 5 years. It will be presented by Dr. Vikram Patra. Then 6 to 12 years by Dr. Sainath from Kolhapur. Then for about 12 years, that would be by Dr. Malvika from Nandurbarg. And then there would be spirometry, it would be by Dr. Aarti, and management of acute asthma by Dr. Smita. Dr. Smita, she is also favorite registrar of Dr. Amdekar, and she was my registrar also. So I welcome you all. Now, friends, to bring the session of Wednesday Wisdom to you, it takes a lot of preparation, because 5 presenters, 2 experts to decide the topic. For that, our team of Women's Committee, particularly Dr. Manjusha Sherkar, Chairperson Women's Committee, Dr. Grevita, Co-Chairperson of Women's Committee, and our convener, Dr. Amrita Bhaviskar. They have taken a lot of efforts and a lot of preparations. So congratulate and all the best to the Women's Committee. Thank you. And over to you, Grevita.
I also welcome Dr. Amol Pawar sir, our Honorable Secretary General Maha-AP, and Dr. Manjusha madam, the Chairperson Women's Committee. Madam Manjusha, Amol sir, your few words of wisdom.
Thank you, Dr. Grivita. First of all, welcome Dr. Barnali Bhattacharya ma'am. It was very nice that you have consented to be an expert to guide our young speakers. And the young speakers include Dr. Vikram Patra, who is also national as well as international faculty. He is expert in allergy. So welcome Dr. Sagar Varankar also, and Dr. Aarti, Dr. Malvika, Dr. Sainath, Dr. Smita, and welcome all delegates, all the Maharashtra IP office bearers of different branches, then executive board members, and all PG students. This is the 3rd year. Just this year now we have changed the name from Tuesday Text to Wednesday Wisdom. In 2022 and 23, with Dr. Gangolia sir and Dr. Ramakant Patil sir as President of Maharashtra IP, this series has been started. and now under Dr. Ram Gopal sir as a president, this series of grooming the young IAPNs or young speakers from entire Maharashtra. This has been continued, and Dr. Manjusha Sherkar ma'am as a chairperson, Dr. Grivita, Dr. Amruta, and entire this zonal EB members of all 5 zones of Maharashtra. They are doing wonderful job in getting the speakers from different from all the branches, and this has been very. This is actually this 7th session of this year, and this has been very popular across India. So many people from outside of Maharashtra, they also join, and almost we are getting more than 400 delegates, viewers in all the episodes. So without wasting time, I hand over to Dr. Girvita to take us further in this episode. Thank you.
Thank you, sir. It gives me immense pleasure to welcome our expert for today, Dr. Barnali Madam. Madam is a consultant pediatric asthma and sleep specialist from Pune, co-director of Casper and Casper Clinics, writing committee and master trainer in many modules of IAP, faculty of advanced asthma course of NRC. And Madam, I would like to make a special mention that Madam is an Odissi dancer. Welcome, Madam. Moving on further, Dr. Sagar sir. Sagar sir is a pediatric allergist, pulmonologist, and sleep specialist from Navi Mumbai and attached to SRCC Hospital, Apollo Hospital, Jupiter Hospital, Sanjeevani Clinic. And welcome, sir. It gives me immense pleasure to welcome you too. So, moving further, I also would like to introduce my co-chairperson, Dr. Vrishali. She's the zonal EB member. So moving further, Dr. Vikram sir is from Navi Mumbai. Over to you, sir. May you please start your presentation.
Gravita, just a minute. Manjusha madam wants to, she is a co-chairperson of the Women's Committee. So few words from her and then we'll start.
Okay. Thank you, sir, so much. Good evening, all esteemed August gathering in this our very popular Wednesday Wisdom Mahayapi Women Committee's program. And सगळ्यांना आषाढीच्या सर्वप्रथम सविनय नमस्कार आणि शुभेच्छा. I take this opportunity to express my gratitude and like to welcome today's renowned expert faculty, my dear Dr. Barnali Bhattacharya ma'am and Dr. Sagar Varankar sir. Mahayapi Women Committee is always humbled with the support of and inspiration from the respected President Sir Dr. Ram Gopal Chejera and Honorary Secretary General Dr. Amol Pawar sir and our scientific convener Dr. Bhavesh Mithia. I also welcome today's MMC observer Dr. Vivek Randive sir. I hope he is there. Friends, I'm very happy to mention the important role always played by my co-chairperson, Dr. Grivita Raikar, in organizing all these Wednesday Wisdom event. And also I thank Dr. Amruta Bhaviskar, convener Mahayapi Women Committee, and Vrushali Sarode, today's moderator. I also, first time I wanted to take all names of my Women Zonal Committee members. Those are Dr. Jayashri Deshpande, Dr. Smita Bajaj, Dr. Lakshmi Kadu, Dr. Anju Kadu, Dr. Swapnali Dhoka, Dr. Prachi Birari, Dr. Swapna Nune, and Dr. Kashmiri Badbade. All these my friends play an important pivotal role in the success of each Wednesday Wisdom program. And the most important are the hard efforts of speakers of this program. And my best wishes to today's all speakers, Dr. Vikram Patra, Dr. Sainath Pawar, Dr. Malvika Kulkarni, Dr. Arti Dammal, and Smita Zategavkar. Dear friends, today we are here to shed important light on important health concern, childhood asthma, affecting millions of children all over the world, limiting their development and well-being. And due to frequent hospital visits, they are affecting physical activities and socio-psychological health, etc. So we are eager to listen to all the speakers and today's renowned experts for their comment. Once again, thanks all my office bearers, Dr. Matin Sheikh, I could see, and all state and central IIP EB members. and all dear friends who all have joined from Zoom and YouTube as well. Friends, remember MMC has granted one MMC point for today's session. So don't forget to write your name in the chat box, MMC number and IIP registration number. And let us pledge to support every child so that he can breathe easily and thrive happily. Thank you. Over to you, Dr. Grivita.
So I welcome Dr. Vikram Patra, sir. Without wasting further time, may you please start your presentation, sir.
Yeah, thank you. Thank you, Grivita. Thank you, MahaIP, for giving me the opportunity. And it's an honor to present in front of Varnali ma'am and my friend, Dr. Sagar. So let's start. My topic given to me is asthma under 5 years of age. So basically, why this is important and uh, is my full screen visible now?
Yes, yes.
Yeah, thank you very much. So basically what we are going to discuss is about the wheezing first. We cannot discuss asthma under 5 years without discussing the under 5 wheezing. So in short, I'll go through the differentials and then our treatment approach, how we should approach a child who presents to us with recurrent wheeze, and if we want to label, whether we can label him as asthma or no. And then we'll go through the GINA guidelines for management of the prevalence of wheeze is almost 50% by the 6 years of age. And 1 in 3 children wheezes at least once prior to their third birthday. So that is so frequent, and we all experience wheezing kids in our day-to-day office practice. But why this age group needs different approach? Because the differentials are more younger is the age. And if you want to label the child to have asthma, the acceptance by the parents is directly proportional to the age. So younger the age, they will not accept the diagnosis of asthma. So, and we need to remember all that wheeze is not asthma. So today we are discussing asthma. So whoever comes with wheezing, we should not jump onto the diagnosis of asthma. We should have a proper history, detailed examination, and we should rule out first the asthma mimics, because these are common in this age group. And commonly what we get, laryngotracheomalacia, foreign body, aspiration syndromes, infections are very common. Here it's not mentioned, but viral infections triggering wheezing episodes, they are more common. And then we can have tuberculosis presenting as wheezing, protracted bacterial bronchitis, immune deficiency conditions, rare conditions like cystic fibrosis, primary ciliary dyskinesia, and so on, and certain congenital anomalies like airway anomalies and congenital heart disease, particularly left to right shunt, they can present to us with repeated wheezing. So let's start with a scenario after going through the brief differentials of the under 5 wheeze. So a typical history, a mother comes to us by saying, my son Aryan, who is 3 years old, has recurrent cough and wheezing for last 1 year. He frequently gets cold which goes to the chest. सर्दी झाली की सर्दी छातीतच जातो. असं we hear these sentences. But before jumping, when she is saying you wheezing, छातीत घरघर होणं, they many a times they say, they use the common word. So first document, ask the parents to have a video recording or an audio recording of the sound, what they feel as wheeze. So first define what is wheeze. Wheeze is a continuous high-pitched sound with musical quality, particularly during expiration. So expiratory sound, which is called as wheeze. So we need to document first, and we have to confirm whether we are dealing with a child who has got recurrent wheezing or no. Then we need to understand, we need to ask questions. How are the symptoms? Now, symptoms having intermittently, having symptoms for few days, in between the child is fine. This can happen 7 to 12 times in a year. And this is what we see is viral triggered wheeze. But always ask how the child remains in between 2 episodes of wheezing. So if the mother cell tells you no, little bit cough is there, little bit wheezing is there on crying, on laughing, on exertion, then you should think of there to have multiple triggers, and then the chances of asthma as a diagnosis is high. So GINA has come out with the probability of asthma. So you need not jump and be excited and label the child to have asthma. So what you can do is you can just determine the probability of asthma. So the symptoms are going to be same, the cough, wheezing, breathlessness, but always ask the duration and the frequency over a period of 1 year. So if each episode lasts for less than 10 days, and each the episodes, the number of episodes is around 2 to 3 episodes per year, and the child remains absolutely normal and no family history, then the chances of having asthma is low. This is called as low probability. Then the next in the series is the same symptoms, but each episode lasting more than 10 days and more than 3 episodes per year, and sometimes even severe episodes leading to night worsening. And the child may have episodes of occasional cough or wheeze or breathlessness in between two major episodes. Then the chances of probability is medium, and then some may have asthma. But what is missing over here and what is going to be there in the next, where you are going to say high probability of asthma, if along with these symptoms, if there are any personal or family history of atopy. Atopy means any allergic tendency to have any allergic condition. Atopic dermatitis in the child, allergic rhinitis, history of some food allergy, and remember family history of asthma, and more commonly family history of allergic rhinitis, what we should ask, because allergic rhinitis is much common as compared to asthma. So then you say that there is high probability of asthma, and most can have asthma in future. So rather than saying asthma, you just mention in terms of, and this should be universal, we should talk in terms of probability of asthma. Then the $1 million question mother may ask, will my child get asthma? Do you have any answer for this? Because you can say they can interchange. Then, but there are few questions, again, in between symptoms, if there are other triggers which can make the child cough or wheeze, that will point out towards asthma. Then, as I mentioned, personal or family history. And then this is important, clinical response. If you ask in the past, after taking sometimes the child might have taken oral bronchodilators or nebulizations, or somebody might have started some bronchodilator inhalers, that is SABA. Then if the child responded, so then again it points out towards the bronchial obstruction, airway obstruction, and then you can think of asthma. Then we have this wonderful modified asthma predictive index. So what is needed? 4 wheezing exacerbation in past 1 year. That is more than 3 episodes of wheezing, with at least one documented wheeze by the pediatrician. Then one major criteria or 2 minor criteria will make you predict whether the child can have asthma. So what are the major criteria? Again, the parental history, mother with childhood asthma, father with exercise-induced asthma, physician diagnosed atopic dermatitis in the child, and recently this has been introduced, allergic sensitization to aeroallergens. So allergic sensitization to aeroallergens means what? Dust mites, animal danders, pollens. So they come in the major criteria. Minor criteria is allergic sensitization to food, milk, egg, or peanut. So aeroallergens, they can cause wheezing episodes, but food allergy rarely they can cause. But yes, and wheezing unrelated to colds, blood eosinophilia more than 4% comes under the minor criteria. So any 2 of the minor criteria, again, strong prediction. So how will we manage? Always after the history, rule out atypical wheezing or the mimics. Then you label the child to have, once you label the child to have a high probability of asthma, or uncontrolled symptoms are there, interval symptoms are there, multiple triggers, allergic markers, number of frequencies more than 3, each episode lasts for more than 10 days. Then always remember, it's a good statement, always give a trial of inhalational corticosteroid. And the corticosteroid which is used in this age group is budesonide, 100 microgram twice a day, give for at least a period of 6 weeks. Because within 1 week, 2 weeks, parents may come and say no response. Wait, ask them to wait for 6 weeks and see. If they come with no response, check the technique, and always check the technique whether they are giving it properly. And if everything is right and still there is no response, then further evaluation is needed. May not be it is asthma. But if the response is good, then what you should do, you should continue for 3 months. And then after 3 months, stop. No need for tapering of inhalational corticosteroids in this age group if we have used for this period. And then watch for recurrence of symptoms. If the symptoms recur, start ICS again, and then we need to follow the China asthma protocol. We'll discuss in our further slides. Now, when we discuss response, what do we mean by response? The control. Control means you ask only 4 questions. Be the patient be on asthma medication, or the patient is naive, not taking any asthma medication. Always ask how many times the child had daytime symptom, means more than once a week. Are there any symptoms, daytime symptoms? If the child is taking SABA reliever medicines more than once a week, and if there are any nighttime exacerbation with activity limitation. So with this, we can label them as well-controlled, partly controlled, or uncontrolled. So now we don't use the term mild, moderate, and severe. We use well controlled, partly controlled, or uncontrolled, irrespective of the asthma medication. And this is what is asthma guidelines. Now you can see, go to the last line, last row. Now, if a child comes to with infrequent viral wheezing, no or few interval in between episodes are less, what we need to give, only we need is inhalational SABA, that is salbutamol or salbutamol you can give. Here there are no evidence for ICS. But if the symptom pattern not consistent with asthma, but wheezing episode requiring SABA very frequently, more than 3 per episodes, and then there is something symptom pattern is consistent with asthma, then we have to start ICS as mentioned, and we need to continue for 3 months. Now, with this medication, if the child after continuous use, you ask those 4 questions after 4 weeks, 8 to 8, every follow up you need to ask those questions. If asthma diagnosis is there and with low dose ICS, the child is not having good control, then you have to double. Now, if the child is taking budesonide 100, 1 puff BD, you ask them to take 2 puff BD. That is the double the low dose. And if there is still no control, that comes the step 4. There we need to have a specialist opinion and assessment by them. Now, when I talked about low dose ICS and double dose ICS, what it means? Low dose ICS of budesonide is 100 to 200 microgram per day, and medium dose is the double the dose, that is 200 microgram per day you can give, and high dose is more than 400 microgram per day. Fluticasone dose for this age group is 50% of the budesonide. And the devices, coming to the devices, always prescribe a spacer whenever you are writing a MDI. And for a child who is less than 4 years, face mask should be used, and above 4 years, directly from the mouthpiece the child can take. Thank you.
Thank you, Dr. Vikram. Our opening batsman is really hitting sixes on sixes. Barnali madam, may you please share your valuable comments?
I think Dr. Vikram did a phenomenal job. To do under 5 weeks and wrapping it on time is excellent. So well done, Vikram.
Thank you, ma'am.
Just a few things that I would like to say is that he did say right in the beginning that importance of history taking and general examination. In all of pediatrics, history taking is of utmost importance. But in under 5 weeks, we need to take a very detailed history because all your red flags will come out in that. If somebody says my child is wheezing and coughing since birth, unlikely to be asthma. Younger the child, more guarded you should be to even suggest a probability. So, or failure to thrive. Like under 5, I'm extremely fastidious about putting them on the growth chart. If you have a child who is coming with recurrent wheeze but is having failure to thrive, it may be a pointer towards a lot of diseases which we think is rare, but it may be that child who is with you and you are labeling it as, a probability of asthma. So be guarded. Or if the hypoxemia is disproportionate to, say, the shortness of breath, it's probably something else. And the other thing that I want to say, he brought about the trial of therapy. This is something that all of us need to know. Many a time, I see prescriptions where budesonide is given with nebulization for 7 days, 10 days, and it's not communicated to the patients. Trial is actually for 3 months. He said after 6 weeks, you review. If the child's technique, adherence, everything is good and still not responding, yes, what is it then? And after 3 months, you need to stop. But in under 5 also, I see a lot of children with a prescription of LABA. Now, that's not a good idea at all, because there are so many Foracort hundreds that we see in 3-year-old, 4-year-old, because you think old in times it used to be hit hard, hit fast. That's gone now. That's why Vikram showed you this stepwise treatment. Know where your child is, put it there. Try. If it doesn't get well, you can always step up. After 3 months, you do step down. But you don't start with formoterol budesonide just because you are thinking that I need to get control fast because it's still not cleared. And I'm very, very glad he did not mention Montelukast, which I'm sure, Sainath coming up next will say. But otherwise, I think it was a wonderful presentation for somebody who knows so much about the disease, to truncate it into 8 to 10 minutes and yet pick up the essence of it calls for a lot of clarity in his thought process. And I think it was remarkable, Vikram. Well done.
Thank you, ma'am. Thank you, ma'am, for your words.
Thank you, madam. I now request Dr. Vrishali Sarode to take over.
I would like to invite Dr. Sainath Powar from IIP Kolhapur to talk on approach to asthma in children from 6 to 12 years. Dr. Sainath, sir.
Once. So, good evening, everyone. I would like to thank my IP office bearers and Women Committee office bearer for giving me this opportunity, and also Dr. Barnali Bhattacharya madam for giving me this opportunity. So, my topic is approach to asthma in children from 6 to 12 years. Dr. Vikram Batra has already covered under 5 wheezing, and now we are coming in an age group where we are crossing 5 and we are entering 6. So here, what is the difference between under 5 wheezing and 6? That 6 to 12 years asthma, we have to confirm our diagnosis, as madam said, wisely said, ki clinical history is very, very important, and examination also we have to do, and we have to go to the conclusion that this patient has asthma. But additionally, here we can have an additional thing, that is we can do a PFT to confirm the obstruction, and also we can check the reversibility by doing the spirometry. So here, above 6 to 12 years, here one thing we can add, that is the PFT. Then GINA recommendations for the GINA recommendation for patients 6 years and above. All patients, this is very important, all patients more than 5 years with asthma should receive one second. Yeah, there is. So should receive ICS containing controller treatment along with the SABA. This is to reduce the risk of serious flares up. So whenever you are using a reliever treatment, it has to be ICS with SABA and not only SABA. In mild asthma, the ICS can be delivered by regular daily treatment as needed treatment along with SABA. So the very important question is, why not to treat with only SABA? So SABA treat the symptom and not the disease. The people with apparently mild asthma can have severe fatal exacerbations, and this exacerbation triggers are unpredictable. It may be any viral infection, it may be allergy induced, it may be pollution or stress. Even 4 to 5 lifetime oral corticosteroid courses increases the cumulative risk of adverse effect to that child. So regular use of SABA, even for 1 to 2 weeks, associated with increased uh, airway hyperresponsiveness, reduced bronchodilatory effects, increased allergic response, and increased eosinophils count. So that is a problem with SABA. So overuse of SABA is associated with, again, increased exacerbation and increased mortality. So starting treatment with SABA trains the patient to regard it as a primary asthma treatment. So the patient will think that this is the treatment, I am taking it, I am becoming fine after taking this blue or green inhaler, and so he will take it as the final treatment. And that will lead to poor adherence to the inhaled corticosteroids, and that is almost inevitable if you use only SABA. So what are the do's in this age group, or we can say all? So inhaled corticosteroids are the mainstay of the treatment, and it has to be used daily. SABA along with ICSR for SOS use as a reliever in this 6 to 12 years age. For children more than 6 years, we may add LABA, long-acting beta-2 agonist, and ICS plus formoterol, not LABA. It is only formoterol we can use for MAT therapy, that is maintenance and reliever treatment. So again, MDI with spacer, generally above 5 years will not use mask. So spacer without mask is the preferred inhalation device for this age group. So what are the don'ts? So this is very important. So Montelukast has got a limited role only as an add-on to ICS. there is a black box warning against Montelukast due to the risk of neuropsychiatric side effects on long-term use. Use of nebulizer. So we see many OPD patients that uses the nebulizer at their home and they are using on their own without any doctor's advice. So use of nebulizer is restricted only to a severe acute exacerbation with desaturations. Rest all the situation will use our inhalers. And nebulizer at home should be discouraged. Nowadays, it is a fashion that when baby is born, we will buy a nebulizer. So we should discourage that habit. So what are the ICS doses in this age group, like 6 to 12 years? So budesonide low is 100 to 200, medium is 200 to 400, and high is more than 400 is high. And if you are using fluticasone propionate, then it is 50 to 100 is low, 100 to 200 is medium, and high is more than 200. So now we are coming proper treatment of asthma in 6 to 12 years. So here when we are going to go on step 1. So whenever there is a symptoms twice a month, and so we'll go with step 1. And there is in this treatment there are two options. First is preferred controller and other controller option. We will generally prefer preferred controller. So we have to give low dose ICS taken whenever SABA is taken. We already discussed this. What is the other control option is that is you can consider low dose ICS. So this is a step 1. So when the patient has got symptoms twice a month or more, but less than daily. So we have symptoms twice a month or more, but less than daily. So we are going to go on step 2. So what we are going to do on step 2, that is a daily low dose ICS. What is another non-preferred option? That is again Montelukast or low dose ICS taken whenever SABA is taken. This is the second option. Then we are going to, if the patient is having symptoms most of the days, and most important thing, or night awakening more than once a week. So whenever there is a word comes night awakening more than once a week, so we have to go on step 3. So what we are going to treat, what treatment we are going to give on step 3? So it is a low dose ICS plus LABA, or medium dose ICS, or very low dose ICS formoterol, which is a MAT therapy. So either low dose ICS plus LABA, that is low dose ICS LABA, medium dose only ICS, or MAT therapy with very low dose ICS formoterol. And what is the another controller option? Low dose ICS plus Montelukast, which is not a preferred option. Then if you have got the availability of pulmonary function test and you have done a pulmonary function test and all these symptoms means symptoms most of the days plus night awakening more than once a week, and there is a documented low lung function on PFTs, then we have to go for step 4. So that is what is the step 4? Medium dose ICS LABA or low dose ICS formoterol, that is MAT therapy. So either you have only two options, medium dose ICS plus LABA, or you can go for MAT therapy. Additional other control options, we can add triotropium or you can add Montelukast. And when you are going to go step 5, if the patient is not controlled on step 4 medicines, then we have to go for, very rarely we require to go on step 5. So we have to refer the patient for phenotypic assessment. We can go higher dose of ICS LABA, or we can add additional anti-IG therapy like omalizumab, and other controller options like add on anti-IL-5, add on low dose oral corticosteroids, but always consider the side effects of oral corticosteroids. And in all these steps, what is the reliever? As needed SABA or low dose ICS formoterol. If you are using MAT therapy, then that low dose ICS formoterol can be used as reliever. So this is the treatment plan of 6 to 12 years of asthma management. So now we'll discuss one case, because already we had discussed the treatment management plan. We'll take a prototype case. So he's a Rahul, 8 years old child. He has got recurrent episodes of dry cough and breathlessness with wheezing since age of 4 years. But last 6 months, he is having increased those symptoms, and he is having repeated episodes with mild symptom most of the days. The cough, so here most of the days is important. Cough leads to nocturnal awakening frequently. The nocturnal awakening is important. He avoids running or playing outdoor games due to the cough and breathlessness. He settles with medications, especially nebulizations, and his parental grandfather has got asthma. So the spirometry was performed on him, and which has shown FEV1 of FVC ratio of 0.7, FEV1 of 70% on bronchodilator reversibility of 14%, which shows that his lung functions are reduced. So here we have got a child with having most of the day symptom. There is night awakening, and we had done the PFT. So he is coming on which step? Now it is step 4. So what treatment we are going to start for him? So medium dose ICS LABA or MAT therapy with low dose ICS formoterol. So this is the treatment preferred, and what will be our reliever? As needed SABA. And or in MAT therapy we can use ICS formoterol low dose. So as Dr. Patra has already discussed, we have to always assess the asthma control level. So these are the GINA guidelines, and we have to assess this patient for last 4 weeks. Again, daytime asthma symptom more than twice a week. Any night awakening due to the asthma. Reliever like SABA for any symptoms, SABA requirement of SABA for more than twice a week, and any activity limitation due to asthma. So these are 4 points. We have to see yes or no. If none of these are there, this patient is well controlled. Is one or two of these are present, then we can say this is partially controlled. And if the all of these or 3-4 of these are present, we can say this is patient is uncontrolled. So we are going to go key points to remember before stepping up the doses. So if the patient is not responding, are you going to step up the dose immediately? No. So we'll first see that whether that patient is adherent to the treatment, whether he is using that inhaler MDI regularly, whether that dose counter is going rightly, means as he is telling actually the dose counter is reducing. Or second thing, technique. Always correct the technique before you stepping up the dose. Again, ensure that there are any comorbid conditions like allergic rhinitis, GRD, etc. And the consult this patient about his environmental triggers that we are going to discuss later. Sorry. So any environmental trigger like where he is staying, whether there is any fungus, whether there are dust mites, whether there is a dust, whether there is a nearby any polluting industry or something. So all these things we have to manage on this step. So then now patient is now consider that patient is now controlled. So when to step down the treatment? So for stepping down the treatment, we have to assess the symptom control over last 4 weeks that we already discussed, and assess the future risk for poor asthma outcomes. And if the patient is well controlled for 3 months and no immediate risk for poor asthma outcome, we can step down the treatment. We can step down by 25%. So what are the non-pharmacological interventions? So avoidance of the medication that may trigger asthma, that is NSAIDs, overuse of antibiotic. We have to give him healthy diet. We have to avoid him all the things which will aggravate his asthma. Avoidance of indoor and outdoor allergens, avoidance of indoor or outdoor pollution, weight reduction if the child is obese, if required, weight reduction, physical exercise, we have to advise them. Breathing exercise may help them. So these are the non-pharmacological intervention. And in this age group, the children are very anxious. Children and parents are very anxious. So they will ask you, why doctor only, why us only? So we have to tell them that you are not the only one who is affected by asthma. These are the celebrities who has already has got asthma, and they have taken a proper treatment, and they are doing very well in their life. So don't say that only you are affected. You take the treatment, so you can also do very well. So what are the takeaway message? So ICS along with the SABA is reliever in 6 to 12 years, not SABA alone. ICS plus LABA can be used in this age group. ICS plus formoterol MAT therapy can be used. PFT can be done in this age group. Montelukast, there is a caution, and avoid home nebulization. So this is the takeaway message. Yes, thank you. Thank you, everybody.
That was very crisp, Dr. Sainath sir. I'd like to call Dr. Barnali ma'am for expert comment, please.
Sainath, well done. You brought out some very pertinent points in this age group. Just to add on a few things is that there is paucity of time. So I'm sure you knew that it would be great to share it, but could not be done because of the time limitation. Is that he hammered on something that in this age group, like we have no objective diagnosis in under 5, which also actually after the age of 3 years, we can now do FOT, and we are working on the Indian normative values, which by the end of this year you will have. But in this age group onwards, there is no running away. That you need to objectively show that asthma is an obstructive airway disease, which is reversible. Now, he spoke on spirometry, and we are going to have a talk on spirometry, which will come up later. So I won't go that route, but each one of us can actually do peak flow measurements. GINA 2024 has categorically now included diagnosis with peak flow. It's actually very clearly given. If you want to read, it's there in page 26. In 2023, it says in resource crunched situations, which India is, where we don't have so many people doing, say, pediatric spirometry, it can be used. But now it is not as reliable as spirometry, but if you can't do it, or if it's not available in your town, please do not feel that in any way you are not doing correct treatment. You can all do peak flowmetry sitting in any interior part of Maharashtra, and you have to just know that after giving bronchodilator in this age group, you will need to give 2 puffs of salbutamol or 2 puffs of levosalbutamol, wait for 15 minutes, and you will see in this age group, it is 15% increase in peak flow, after the bronchodilator. And if you show that having a setting of asthma, sometimes parents, like what Sainath said, that, are you sure? Does my child have it? And you don't have a spirometer, you can show them, and you can show them that, look, it was 100 and now it has come up to 130 or whatever, and it helps in helping them accept it. There was a question that came up, that is March therapy useful? I would tell the doctor that just hold your guns. Dr. Malvika is going to come up after this, because we talk about March therapy more in the age group beyond 12. But yes, March therapy is more useful because adherence is better because you're using a single inhaler. But in this age group, it is very difficult to titrate the dose, because it's very low dose which goes as a reliever, and that becomes then only one OD puff of formoterol budesonide and one SOS, which becomes difficult for anyone to accept. Another thing which he's made in passing the correct device, and he said that we can always use a spacer. And here I would like to say, most of the children who come to me in this age group have the huff puff kit. Because ek zamane mein you've given them the huff puff kit, they attapan chalte. That won't do. The moment your child becomes 4 years, please knock off that mask, because you're increasing the dead space. And we see very established consultants also doing it, very established intensive care from high profile corporate hospitals also doing it. And so don't think that if they've written it, that can I change this prescription? No, knowledge is key. So if you know it, that I am not supposed to be doing it, please change the device, because they are not supposed to use it. Again, a very good point that Sainath brought forth is nebulization. I'm sad to say that 70% of the kids who come to the practice with asthma, they all have the nebulizer. I asked them an open-ended question that, वापासाठी काय करता आपण? He says, आमच्याकडे मशीन आहे मॅडम, with great pride, status symbol. So my first thing, I don't even go beyond in the history. I mean, I will ask them, but my first thing that goes in my prescription in block capital is no home nebulization. I hope, even if this one thing you can take from Sainath's talk is, do not prescribe any home nebulization. Do not give any Sava. Mild ahe. Tumhi tila blue pump vapra. You can kill that child. Like he said, that, mild asthmatic. So what happens in this age group predominantly is nebulization, oral steroids, and not an appropriate ICS So please correct that, because this is the bulk group, and you can ruin their airways for life. So peak flow, we should all know. Home nebulization, none of us should promote. Montelukast, no. And of course, and don't say your asthma is mine. Sitila ahe, bagu apan. Don't give them the thing. Don't get into any popularity mode by counsel them correctly. Like, what is the Gina slogan of this year? That education empowers. So whatever you transfer that to the language that they understand. I think I'm done. We can move.
Thank
Any
you.
exception to this general rule of no home nebulizations? Any exception to this?
Any exception would be a very mentally subnormal child whom you just cannot give the inhaler, with a spacer, or a child who might have a spinal disorder, and you can't. But in my 30 years plus of asthma, I have probably not needed to use it, and because those are very, very so. Except that some grown-up kids, who may be mentally subnormal, I may need to use a mask with their spacer, but I still don't use a nebulizer.
Thank you.
Thank you, ma'am. Thanks a lot. I would like to invite our champion pediatrician from Shahada, Dr. Malavika Kulkarni, for the next talk, that is asthma in children above 12 years.
Good evening, everyone. Are my slides visible?
Yeah.
Yeah. At the outset, I would like to thank Maha IP and the women's team for allowing me to represent my district in the Wednesday Wisdoms. I am Malvika Kulkarni from Shahada, which is in Nandurbar district. And I also thank Dr. Barnali madam for fine-tuning my presentation and helping me with it. My topic for today is asthma in children above 12 years of age. So adolescence, as we all know, has a lot of physical and psychological changes that they are undergoing. And also we have to remember that in adolescent age group, the parental surveillance is not as much as it is in below 12 years of age. So they have a lot of psychological stress going on. There are anxiety issues, sometimes depression, which leads to non-adherence to the regime. There is poor symptom control and hence poor treatment outcomes. And adolescents are always it is said, at increased risk for asthma, morbidity, and mortality. Hence, the goal is always to give the best asthma control with the least amount of medication. So as in any case, the diagnosis would be a good history and a clinical examination. And apart from all the various symptoms that have already been mentioned in detail, an adolescent will always complain of tightness of chest. So this has to be asked for. So once we have come at a diagnosis based on the symptoms, we have to see for response to therapy. As madam already mentioned, there is no escape in above 12 years of age for not doing a pulmonary function test, now that peak flowmetry is available even in Shahada. So variable expiratory airflow limitation has to be documented. Even GINA 24 specifies that the obstructive airway disability with a positive bronchodilator responsiveness, which is termed as reversibility, is one of the criteria for the initial diagnosis. And also it mentions that even a peak flow meter is good enough for a confirmation of our diagnosis. Asthma management has to be personalized. So once we have done the spirometry, we have to analyze for comorbidities. Once we have given the inhaler therapy, we have to, in adolescents, check for adherence. We also see for the risk factors that are there, the triggers, and we keep reviewing and reassessing our management. So treatment modalities. So there are two scenarios in which we start treatment. One is an OPD setting when the child comes to us in an OPD and we have diagnosed asthma, or it could be after discharge from the emergency department. So the treatment is an anti-inflammatory reliever based therapy. budesonide with a formoterol combination, which is called maintenance and reliever therapy or MART therapy, which includes a low dose, that is 200 micrograms of budesonide and 6 micrograms of formoterol. That means that is one canister contains in one actuation 100 micrograms of budesonide and 3 micrograms of formoterol. So we give one actuation twice a day. So maximum recommended dose for reliever therapy would be 12 actuations, that is 72 micrograms of formoterol. Now, Gina mentions 2 tracks for therapy. The first track, which is the most preferred track, is the MART therapy. And the advantages being that it has been proved by various double-blind studies that there is greater reduction in the severe exacerbation episodes, lesser cumulative steroid dose is given, lesser emergency visits, and better symptom control and better adherence to therapy, because we are just giving them one canister to maintain. They don't have to carry 2-3 canisters with them. As it is, it becomes complicated. In the track 2, there is, which is the less preferred treatment protocol, is we give a reliever with a short-acting beta agonist as required. And also there is the anti-inflammatory therapy where SABA is given with an inhaled corticosteroid. In the track 2, the maintenance therapy would be in the step 2 would be low dose maintenance inhaled corticosteroids. Step 3 would be a combination of inhaled corticosteroid with a long acting beta agonist. Step 4 would include medium and high doses. These have already been covered. So moving on to the more important and the MART therapy, the track 1 of GINA guidelines. So if there are symptoms that are less than 4 to 5 times a week and the lung functions are normal or mildly reduced, we go for the step 1, wherein we are giving low dose inhaled corticosteroid, that is budesonide with formoterol as needed. If the symptoms are for most of the days, the child is waking up because of asthma and the lung functions are having reduced functions, then we are going for the MART therapy, that is one actuation twice a day in the low dose maintenance therapy. Step 4 would include daily symptoms or waking up at night with asthma at least once a week, and definite spirometry changes are seen. Here we are giving medium dose of MART with 2 actuation twice a day. Now, in spite of all this, if the child is not maintaining and needs, there are exacerbations continuously occurring, this is when we need to contact Dr. Barnali madam or any respiratory specialist around us. We need to analyze the child's phenotype and the biological therapies if needed. High dose maintenance therapy can be given here. Here also we should mention that there may be a need for giving a short course of oral corticosteroids if there is severe uncontrolled asthma. So points to be remembered always is, while giving treatment to adolescent in asthma, is that MDIs should, again, even in 12-year-olds, should be given with a spacer. MART therapy is the reliever and controller therapy of choice. The adolescent should be given a action plan for asthma, which should include all the treatment modalities that are being explained to him, the step-up protocol, what should be done if the child experiences wheezing or other symptoms, then when to take the oral corticosteroids, when to visit the ER. All these things have to be told and have to be given in a written document. We should encourage them to keep a diary of their therapy, their exacerbations, their triggers. Peak flow metry can be given to the child, wherein diurnal variation assessment can be done by the child, noted in the diary. The specifics of this will be mentioned by the next speaker. And we have to address the comorbidities, that is obesity, allergic rhinitis, other allergies that the child might have. And whenever the child comes for follow-up, we have to assess the technique of the inhaler therapy that the child is using, recorrect it if need be. So the assessment of poor control includes check our diagnosis, see if we need to have an alternative diagnosis. We have to check for comorbid conditions like obesity, gastroesophageal reflux, allergic rhinitis. We have to check for the inhaler, the dose, if it is appropriate, the device, and the delivery of how the dose is being given. Apart from all the other triggers, adolescent age group, we have to ask for perfumes, deo sprays, room fresheners, and checking for adherence is the key. Thank you.
That was very clear and concise, Dr. Malavika ma'am. I'd like to call again Dr. Barnali ma'am for expert comment.
Malvika, well done. You brought out some very pertinent points. She focused on adherence huge, because as we all know, I mean, if you have adolescent as your kids or your siblings, if you're young, or so, it's a difficult age group. They are neither children nor are they adults, but they think they have a mind of their own. So they don't want their parents to supervise. So half the time they are not taking. So hence, the MART therapy is of huge importance in this age group. That's why it's the preferred track. That's track 1. Because if it is one inhaler, maintenance and reliever therapy, one inhaler, then it becomes that much easier. She also said that, you can do peak spirometry, and she said even in her place, she showed us there on the map where it is. Like, I myself wondered from where does Malavika come, and and I was curious, but that was her first slide, so I'm sure a lot of you would be wondering where she comes from, and so even they have a peak spirometer. That's the way knowledge is percolating. Once upon a time, when 27 years back I came to Pune, they used to laugh at me because I carried my peak spirometer. That, they खूप time घेते, with an Dama patient, and she's stuck with one. But, that's the way to go. The other very good point that she brought about is comorbids. Remember that 70% of any one of them, even Sainath could have brought it up, but that's okay. See, all of them, because I saw all their presentations, there was no overlap. Because if there is overlap, then it gets boring for you and we don't cover grounds. So she brought about the comorbids, and she very well mentioned allergic rhinitis, gastroesophageal reflux, which is probably less in this age, but she brought about obesity, which is huge. Post-COVID, you see so many fat adolescents, which we didn't see earlier, because, they sat at home and then they got used to their screen, and now they rather watch something on, do Instagram posts than go and play with their friends. So obesity and allergic rhinitis, 70% of asthmatics have a concomitant allergic rhinitis. And if you don't manage that, you don't go anywhere. Now, there were a few questions coming up, so I will answer them. Somebody asked that in this age group, is it MDI or DPI? Well, across the board, whether it's ATM, whether it's any other training module, right now, Casper, we say that MDI with spacer is the best device. However, you can use DPI. Why DPI? Because sometimes the inspiratory flow rate they can't generate when they may be in a flare up. So DPI may be okay for daily control, but DPI may not be such a great when you're having a mild flare up, which perhaps may get covered when we are doing acute flare up though. And the other device that you can probably use is a breath actuated inhaler, where you need to generate very less force. However, in the interiors of Maharashtra, you may not get breath actuated inhaler. It is also a little more expensive. But like she said, that in this age group also you need to take a spacer. So sometimes they say, attapan tila bhanda deche ka. So then I say, even if I get dama, I will also use it. So you have to tell them, otherwise they might stop using the spacer on their own, thinking that now he's become big and he's become smart and he doesn't need to use it. I think those were the points that she brought out, and she showed you the Jina Chakra also, because that is the way. And something very important, this is an age group where you need to talk to them one-on-one. Even if the parents are saying, you ask them what their expectations are. I mean, are you okay? You're going to be fine. And particularly for girls, a lot of asthma flare-up happens when they attain menarche. So when you have in your practice a girl who's 10 and you're treating for asthma, be very mindful about her menarche, because that's the time there could be a little bit of a flare-up, and which both Dr. Vikram and Sainath, they mentioned their doses, low dose, medium, high dose. Malvika didn't do that, but probably because of a paucity of time, and she covered a lot of ground. In this age group, your low dose is 200 to 400, your medium dose is 400 to 800, and your high dose is more than 800. And believe you me, most of our patients get controlled in step 3, step 4. They don't need to reach 5, provided you check adherence, provided you check technique, provided you check comorbids. You saw in step 5, she said OCS. And how many of you may be writing Titpred, Visolone, Umnacotil, they do naka, because I think Sainath said that 5 courses of it can change the milieu for a lifetime. So you owe it to the kids not to, treat them not correctly. I think I'm wrapped up with all the 3 whom I mentored. And
there is one question here, ma'am. Can you
yes,
please throw some? There is one question here.
Volume of spacer.
Yeah. Can you
Yeah.
please
So I
throw
saw
some?
that question. Let's not use pharmacological name like a zero-stat BT spacer. Any spacer which has a valve, a one-way valve, a volume of 200 ml is a good spacer. There are multiple spacers in the country where the valves are two-way, or the valves are fish mouth valve which don't open so well. Those are not great thing. You no longer need that big volume spacer. Just a single breath technique in this age group, more than 12 years, you have to teach them the single breath technique. Shake it, breathe out, actuate, and hold it for 10 seconds for the gravitational sedimentation. This age group is single breath. In Sainath's age group of 6 to 11, you can, either do 6 breath or single breath, depending on, because that age group is a big. The difference between a 6-year-old and 10-year-old is huge. And Malvika mentioned in March that a maximum of 12 puffs you can use of formoterol and budesonide. And in as far as if you use March in the less than 11 years old, then the maximum doses that you can use is 8, because it goes on the number of formoterols. So, you cannot use much more than that. Did we cover all the questions in the chat?
Yes, ma'am. There is one. Can you please throw some light on synchrobread devices and mini zero stat spacers which are now available in the market?
Okay, please do not use the mini spacer at all. The volume is inadequate and the valve is very tight. So if they come to promote you the mini spacer, the answer is say Malanako. I will use your company zero stat baby spacer, but do not promote it to me. And also spread the awareness around you that if I see it on a prescription, and I will probably call up the pediatrician and say that, it's not a good idea. I'm very happy that you chose a spacer, but not spacer. Synchro Breathe is the breath actuated inhaler. Synchro Breathe is a brand of Cipla, but breath actuated inhaler as of now is only theirs till the August term. Why is it called breath actuated? Because it is your breath that actuates. It's not by pressing. Okay? And you need to also prime it differently because there's a little notch behind. So if I see children, who are 11, 12 years and beyond, who needs another thing you must know, Synchro Breathe is available for us pediatrician only in formoterol budesonide 200, and it's there in Livolene. So if you're using MART and your patient is in the age group where you will be needing 200 BD, only then use Syncrobid. Many a time parents are sitting outside and they see someone using a Syncrobid, there is no Bhanda and all, they say, Mala pante paije. Then you say your child is on formoterol budesonide 100 BD. We are lucky he is on this low dose. So why should we use that? So that's what I think Grivita in her thing, she says information is key. This is the information. He doesn't know. They feel they are using something fantastic. So why shouldn't I be using a savvy device? But they don't know that it is only there in one strength. Well, they did promise us that it is going to be launched in January 2024 for Formoterol Budesonide 900, but we are still waiting. And the other very good thing that Malvika brought out is deodorants. This is the time that body odor starts because of the hormones, right? And so you have to tell them that it's not a good idea because it's a known trigger, you know. And so you need to educate them. And if you tell them that, you know, it's okay, just bathe well and use an, you know, with a nice soap, and just don't kind of, because particularly boys, they will just drench themselves in a thing. And then they come to my clinic, my nose gets twitchy because of the deo. So you have to educate them. You have to involve yourself with the family that's sitting across you.
Thank you so much, ma'am. I would like to call upon our next speaker, Dr. Aarti Dambal, for the talk on investigation spirometry. Dr. Aarti?
Aarti, unmute. Unmute yourself. Dr. Aarti, will you unmute yourself?
Kindly unmute.
In the meanwhile, there is one question in the chat box. Can we take
madam,
that?
तुम्ही unmute
Role
करा
of
ना त्याला.
role
Sir,
of
request
terbutaline
आती
in
है.
OPD.
Roll off.
Request के लिए already.
Terbutaline in OPD. Roll
of terbutaline inhaler.
In OPD. In OPD. Role of terbutaline in OPD. Ma'am, you're not audible.
Audible.
No. In syrup form, where is he? How is he wanting to give terbutaline? Syrup. Doctor, if you want to give a bronchodilator, it would be better to use an inhaled bronchodilator, which Dr. Vikram mentioned in his first talk, right? But if you're using one-off, not for an asthmatic, and you want to use a cough syrup and you want to give a cough syrup with the terbutaline, so be it. But if you are convinced that it's an asthmatic, then you surely should be using the inhaled route to deliver the bronchodilator.
Ma'am, presentation is visible.
Am I audible?
Kindly make it full screen. Yes, ma'am. Kindly make it full screen.
Somebody's volume is on. Kindly mute yourself.
Now it is visible, audible.
Yeah, audible, visible.
Okay. Good evening, everyone. I'm Dr. Aarti Dambal from Dharashiv, that is Usmanabad. Thanks a lot, my IP office bearers, for giving me opportunity to talk on spirometry. Thank you, Bernali ma'am. And I will start. So, what is spirometry? In majority of lung diseases, be it obstructive or restrictive, ventilation is predominantly affected. And what spirometry does, it measures the combination of lung volumes and it provides the information about physiologic derangement of the lung. It is most important pulmonary function test. These are two spirometers we can see. This is portable handheld and this is the mini version pocket spirometer. Then age group, it can be done in 6 years and above that. And what is the technique? Spirometry looks at how fast your child can blow air out of their lungs through the airways. Child is asked to breathe in until they are full and then blow out as hard as and as long as they can through a mouthpiece. Then what are the types? First, basic handheld spirometer. It provides FEV1 and FVC values that can be compared manually with the available predicted normal values. Next generation, it provides graphs, usually time volume curves with or without printouts. Most recent ones, they calculate the percentage of predicted normal values based on reference values already programmed after we enter the patient's details. Then how we should prepare the child. The environment should be child friendly. Before the test, make the child familiar to the lab, the instrument, the persons who are going to perform. Mouthpiece is given 1 to 2 days prior to practice at home so that the child will be confident and comfortable. Child's torso and head should be erect during the procedure. Nose clips may give better results. Child should take slow breath, then full inhalation, brief hold, sustained exhalation with maximum efforts as long as possible for at least 3 seconds. Then child is allowed more than 3 attempts to achieve the above. An ideal spirometry should include at least 2 reproducible curves with a difference of less than 5%. And the best accepted curve is the one which has largest sum of FEV1 and FVC. Then in short, we will see lung volumes and capacities. Tidal volume, that is TV, volume of air inspired during tidal respiration. IRV, that is inspiratory reserve volume, volume of air inspired by forcible inspiration after tidal inspiration. Then ERV, expiratory reserve volume, volume of air expired by forcible expiration after tidal expiration. Then RV, residual volume, volume of gas remaining within the lungs at the end of maximal expiration. Then FVC, it is most important, forced vital capacity, denotes the quantity of air expired forcefully after maximal inspiration. Then FRC, functional residual capacity, the volume of gas remaining in the lungs at the end of tidal exhalation. Then TLC, total lung capacity, gas contained within the lungs after maximal inspiration. Then inspiratory capacity, volume of air inspired by deep inspiration. This is the diagram showing all the volumes and capacities. Spirometry does not measure individual lung volumes, but it measures FVC, that is forced vital capacity, and the other 3 parameters, that is FEV1, forced expiratory volume in 1 second, then FEV1 FVC ratio called as forced expiratory ratio, and FEF 25 to 75% of vital capacity. These 3 are measured from FVC. This is the time volume curve. Spirometry usually computes the largest value of FEV1 and FVC, even if these are from 2 different curves. During FVC maneuver, the expiratory volume is plotted. Here it is volume, y-axis, and x-axis, it is time in seconds. This is called time volume curve. Spirometry indices are reported comparing individual's value along with the predicted value. Here we can see the indices and the difference between obstructive and restrictive. First is FVC. It is reduced in both obstructive and restrictive. Normal is 100 plus minus 20%. FEV1 reduced in both, normal 100 plus minus 20%. The ratio FEV1 to FVC reduced in obstructive diseases, but normal or maybe increased in restrictive. Normal is more than 80%. Then FEV 25 to 75%, reduced in obstructive and restrictive, normal 100 plus minus 35%. In normal individuals, more than 80% FVC can be achieved in first second. And FEV1 denotes the fraction of FVC expired during first second. Then most important is forced expiratory flow, that is 25% to 75%. It is measured from the FVC curve by excluding first 25% and last 25% of expiratory flow. It is called as maximal mid expiratory flow rate, MMFR. It evaluates small airways, and it is more sensitive indicator of small airway obstruction than FEV1. Then modern spirometry curves. These are the flow volume loops. Volume is on x-axis, flow on y-axis, and upper half shows expiration, a lower half inspiration. This is the normal curve. These are flow volume loops. Outside one, this is normal. Then this is restrictive pattern, and this one is obstructive pattern. That is reduction of vertical axis, decrease flow in obstructive diseases. It alters the shape of the loop. And when there is reduction of horizontal axis, that is x-axis, lung volumes are reduced. That is restrictive lung disease. It alters the size of the loop. Here it is actual video of the child performing the test. So actually this video shows how the spirometry is performed. Then we will see some cases. This one of Durwang. This is the report of the test. Here are the patient's details: age, height, BMI, weight, previous history, etc. Then here are the actual results. This is pre and this is post. Pre means before bronchodilator or when the patient arrives to your OPD, and post means after giving bronchodilator therapy. And LLN, this shows lower limit of normal. So in this case, FVC, FEV1, and the ratio, these are all normal. Ratio is mildly decreased, but it's okay. It is a normal reading of spirometry. He is not having any disease. Second case, this is of the area. Here are the patient's details. And in this, we can see the pre-results here. FVC was reduced. FEV1 was reduced. The ratio was reduced. And these indices are dramatically improved after giving a bronchodilator. There is improvement in this, we can see here. So this is showing obstructive pattern and which indices are recovered after giving bronchodilator therapy. So this is in favor of asthma. This is third case of Riyansh. Here are the patient's details, and we can see the indices here. FVC is decreased, FEV1 is decreased, but the ratio is increased. So this is in more favor of restrictive pattern of lung diseases. So these are 3 case reports we can see. Thank you.
Thank you, Dr. Aarti. I would like to call now our next expert, Dr. Sagar Varankar sir, for expert comment, please.
Hello everyone, good evening.
Good evening,
Sorry,
sir.
it's already very late. I think Dr. Aarti has done an excellent job because, see, previous speaker, it was easy for that particular talk, to get a lot of information from internet and, presenting in front of all of you. But this is something which is very practical and is very difficult. And somebody who has never done it, who has never performed it, who has not, knowing the instrument also, I think she has done wonderful job. Certain points which is very, very important. So I'm not going to talk about detail about spirometry. What I have understood from this, what is lacking. So as a pediatrician point of view, you must see the curve. So if you go, I think, Dr. Aarti, can you go to any curve? So we can go to that. So most important is the curve. So first visual impression is very, very important. You can go to first slide. This is okay. That one, the previous one.
Previous.
Third case. Go ahead. Yeah. So if you see this is very important. First of all, so the spirometry is dependent on your age, sex, which population you belong to, whether it is Asian population or Caucasian. So that is very important. Height is very important criteria, one of the criteria on which your spirometry is based. So the most important, the start should be good. Okay. And there's something called as, you know, when used the initial period, that is called as back extrapolated volume. If it is less than 5%, so when you if you see the x and y axis, on y axis, if you see the flow, if it is starting more after 5 seconds, after 5 to say up to 5 seconds or something, then it is not going to give you a good result. So that is called as back extrapolated volume in FEC. So it should be less than 5%, which is good here. Second, simple thing, there should not be any cough artifact in cough artifacts when your child is doing this spirometry. There should not be any glottic closure. And the mouthpiece, which is holding the mouth, it should be properly. There should not be any tongue in between. So that can be seen. So the curve should be very smooth while going up and while coming also. And during inspiration, so the above the x-axis is nothing but your expiration. Below it is called as inspiration. That is very important. Second, more than 6 years, the criteria to say that this test has been done properly or to accept. So acceptability criteria or repeatability criteria is nothing but the FEC should not, it should be less than, the difference between two FEC should be less than that is 150 liter, 0.150 liter, that is 150 ml. Should not, the difference should be less than this. Less than 6 years, because sometimes we can do for less than 6 years also. So there it is not 150, it is 100. So that is one important. And in this report, as a pediatrician, 3 things what I will say to look for, not going into too much detail. So whenever this type of report comes to you from anybody who is performing the spirometry, the most important thing as a basic what we have to see is FE1 by FEC ratio. If it is less than 80, okay, more than 80 is normal. If it is less than 80, that means we are dealing with something called as obstruction. So if this is less than 80, that ratio FE1 by FEC, then you go to FEC. That percent predicted should be again more than 80. If it is less than 80, then we know that child is not able to blow till the end properly. That is for adult, it is 6 seconds. For pediatric, we can take less than 10 years, we can take as a 3 second also. So that is another criteria. So more than 80% is FE1 FEC ratio. If it is less than that, you know we are dealing with obstruction. If that FEC, again, if it is less than 80, then it is obstructive disease, as well as there is chances of more severe obstruction. But usually more than usually in asthma or in obstructive disease, the FEC is always, most of the time, is more than 80, because here is a child who is having blockage in the airway. There is no problem in the lung parenchyma or muscle, so he can blow more than 6 seconds also, because there is a lot of lung volume inside the inside the lung. But because of blockage, he will blow slowly, but he will blow more than 6 seconds also. So that is second point you have to see. So FE1 FEC ratio, then FEC, and then what you have to see is post change. If the post change force expiratory volume at 1 second, this is showing change more than 12%, that gives you idea there is a significant post bronchodilator positivity. So 12% is the criteria that you can see post change in percentage post change. So here you can see it is 19, 19. Second column FEV1 19% change, post. So more than 12%. Yeah, second you can see the 19. Post, come right. Can you see the 19 volume 19? So that is the post change. So if it is more than 12%, then we are dealing with something reversible airway obstructive disease. Other than that, I think if these three parameters also, if you see, that is more than enough.
In percent or 12?
12%. The post change in FV1 more than 12% gives an idea there is a significant post change. So it's a nothing but reversibility. Okay, whenever there is reversibility, we know it's a reversible obstructive disease, that is asthma. So these are the very important. Rest I think you have covered very nicely. Along with this, I think everybody should try and do wherever possible. Spirometry is very, very essential. I think try and learn spirometry and try and start doing spirometry at least in your place, or you can get help of these companies who are providing MDIs and inhaler devices. They can give you devices once in a month in your OPD, and then you can start doing it, because it gives a confidence to yourself as a pediatrician, as well as it gives confidence to the patient, whether my patient is improving or not. Or as Barnani madam has already mentioned, PFR is a very good device. So 20% change in daytime and evening time gives you idea that definitely there is something called as obstructive airway disease.
Thank you so much, Dr. Sagar sir and Dr. Aarti. Last but not the least, coming to the last topic of the day, management of acute exacerbations in asthma by Dr. Smita Jattegaonkar, madam, from IIP Varda. Over to you, madam.
Smita madam, kindly unmute yourself.
Okay, can you hear me now?
Yes, ma'am, but presentation is not visible.
Madam, you have stopped sharing.
Yeah.
Now
Can
you
you
are.
see now?
Yes, madam. Yes.
So good evening. And I know this is my last presentation, so I will definitely see to it. It will be very quick, short, and brief. So the topic which is important is the acute exacerbation management in children. As you all know, and the Banali madam has rightly said about the World Asthma Day and the slogan for this year, I have already displayed it, and already madam has already said information is the key. So that is really important. And I really thank everyone to give this platform to discuss such an important topic in this year. My slides are not moving.
No, not moving.
Madam, double click it.
Okay, so quickly now with these objectives, like how to define acute exacerbation with pathophysiology, what will be the symptoms and diagnosis, the risk factors, the how to classify the severity, management under 5 and more than 5 years in PICU, what will be the discharge criteria, and the important take-home message. I will try to be very quick as possible, but try to say the important salient points. So all of us, we know the acute exacerbation, basically it is characterized by a progressive increase in symptoms. At the same time, there is a progressive decrease in lung function, which require a significant change in the treatment. It can be seen in a pre-existing patient with asthma, or it can be the first manifestations. So the best and the most important, I think, okay, so the appropriate word will be a flare up, because we all know the asthma is a chronic disease, and already there is a chronic inflammation. So during flare up, we know there is a bronchospasm, mucosal edema, mucus plug causing airway obstruction, leading to hyperinflation and ventilation perfusion mismatch. So the most important treatment will be acute SABA, it is, or LABA, it is a bronchodilator. The another one will be anti-inflammatory drug, that is oral steroids. And for the ventilation perfusion mismatch, it is the oxygen, that is an important drug to be considered. So the symptoms will be progressive worsening of the cough, rapid breathing, difficulty in breathing, the tightness of the chest as mentioned in adolescent girls or boys, acute wheezing or sudden increase in wheeze. The nocturnal cough is very hallmark of the asthma, exercise intolerance or lethargy, impairment in daily activity, poor response to reliever therapy, and the reliable indicator for airflow obstruction will be a significant decrease in peak expiratory flow, or the FEV1. As madam has rightly said, we should start using more frequently, and we cannot manage asthma without this in elderly patients. So this is a very inexpensive tool which can monitor the improvement or worsening. So it is extremely important now in diagnosis as well as in management. So these are the risk factors for exacerbations, and whenever we take the detailed history and examination, we should look for this to prevent the subsequent exacerbation in children. So under 5, maybe the more commonest will be the viral, but the modifiable risk factors will be like high SABA use, we have already discussed, inadequate ICS, poor adherence, and the incorrect technique should be taken care of. If the patient has history of intubation or admission in PICU for asthma in the past, or the severe exacerbation itself, it is an important risk factor for future admissions. So similarly, the exposure, psychological stress, and the low lung functions, food allergy, and the comorbidities, I think majority of them we have already discussed, but we need to treat or take care of these to prevent the exacerbations. Coming to the severity of asthma, we all know by taking a good history, examination, signs, and the objective evidence in the form of breathlessness, how the patient talks, whether the patient is alert or not. The consciousness is the most important thing, because hypoxia, whenever sets in, first thing it will affect the sensorium. So if there is a patient is talking irrelevantly or agitated, or if the patient is having hypoxia, so this is an early marker, and we have to admit this patient in PICU for an appropriate management. Similarly, the use of accessory muscles, wheezing, then the tachycardia, tachypnea, pulsus paradoxus, and the peak expiratory flow, and PaO2, PCO2, and the SpO2. So these needs to be monitored, because we all know the exacerbation can progress very rapidly. So at a given point, we should know what we are treating. There are various pulmonary index scoring, and the British Thoracic Society classifications are available, and we should know that the exacerbation of any severity can occur in patients in any severity category. So if the patient has a severe exacerbation is possible if the patient is having intermittent asthma, or vice versa. Now coming to the management of acute exacerbation in children, we cannot manage asthma without an asthma action plan. So the take-home message is, whenever we are treating these patients, we should give them a written asthma action plan. So the home management of acute exacerbation starts with this. Below 5 years, this plan will definitely help to recognize an impending attack, to start the treatment, and to refer on time. The initial treatment is inhaled SABA below 5 years with MDI, with spacer, with mask, and definitely no nebulizer. The medical attention should be taken early. And here the GINA says, for parental initiated oral steroids, there is no supportive evidence. So parents should not start oral steroids on their own. However, when we are referring this patient, if it turns to be a severe exacerbation, then the healthcare personnel can start the oral steroid and then refer. In more than 5 years, Again, the peak expiratory flow monitoring is important. Strict no to inhaled SABA alone, why we have already discussed, and it is an anti-inflammatory reliever should be used, and we have discussed track 1, step 1 and 2 MART therapy also. Coming to the most important, mild to moderate exacerbation can be managed well with inhaled salbutamol and ipratropium with MDI and spacer. Again, we all know it is a good effective SABA delivery can be achieved. The ipratropium can be given in the second hour if there is a poor response to the inhaled salbutamol. Gina says we should use ipratropium only for 1 hour, but BTS says we can use it 6 hourly as and when required along with SABA. The controlled oxygen therapy is utmost important if there is a hypoxia. The syrup should be used in less than 5 years old children, oral prednisolone, 2 milligram per kg. Within 1 hour, it should be used because the action starts 4 to 6 hours later. The doses we all should know below 2 years, it should not exceed more than 20 milligram per day, and 2 to 5 years, 30 milligram per day. In severe cases, we need to admit these patients in PICU. But if there is a poor response, the alternative diagnosis should be considered. In above 5 years, again, it is the SABA and inhaled SABA with ipratropium, controlled oxygen if hypoxia. The steroid dosage should be not to exceed 40 milligram per day. The high dose inhaled corticosteroids not found very effective in children who are already taking ICS controller, and however, it has been shown that it reduces the duration of hospital stay. Continuous monitoring for deterioration or the improvement is very important, and we need to manage the severe exacerbations in PICU. So airway, breathing, circulation is utmost important with continuous monitoring. Pulse oximetry whenever we are giving oxygen is a must. IV access to maintain hydration. Sedation should be avoided. We should investigate rationally. So the ABG is important to detect the hypoxia, hypercarbia, CBC, CRP to rule out infections. XHS routinely is not required. However, if we are suspecting complications and infections, we can do it. Serum electrolytes are important, especially hypokalemia, because we are using SABA and it can lead to hypokalemia because it causes shift of potassium, and hyponatremia because SIADH is very common. The oxygen is a drug. It should be used. And in PICU settings, whenever there is a severe or life-threatening exacerbation, we should monitor SpO2 between 94 to 98% by giving high-flow oxygen system. The nebulization here, we can give it oxygen-driven. Continuous nebulization with salbutamol is also found to be effective. The systemic steroid should be given only when patient can't take the oral prednisolone. Otherwise, IV versus oral both has equal efficacy, and the dose also we should not exceed more than 40 to be given for 5 days in children. The injection magnesium sulfate IV bolus can be given for stat or can be repeated as it is required. However, the inhaled large dose corticosteroids, they have found to be useful given early, but with systemic steroids, the conflicting evidence is obvious. If patient shows a resistance to this therapy or there is an impending respiratory failure, the non-invasive ventilation can be tried. But if there is a cardiorespiratory arrest or the PO2 is falling on 100% oxygen, PCO2 is rising, then we have to intubate the patient, and the crucial role is careful monitoring. However, with a good care, most of the patients will definitely improve. The mortality is low, and the sequential tapering of the support system and with medications like last in, first out. We always remember that whenever there is hospitalization in PICU admission, it is a red flag for subsequent serious exacerbation. The GINA says poor evidence for IV salbutamol or terbutaline, but can be used in refractory cases. IM adrenaline is only given when we are suspecting anaphylaxis or angioedema. IV aminophylline, we all know it has poor efficacy and safety with narrow therapeutic index. And IV ketamine should be used in refractory cases with monitoring. Already we are again and again stressing that leukotriene receptor antagonist in acute asthma has definitely no role because neuropsychiatric and behavioral problems. Antibiotics should be used only when there is a confirmed or a infection. Otherwise, it should not be used. The sedatives drugs strictly avoided. And once the patient is improving and is ready for the discharge, we can consider the discharge with proper education. The arrange at the discharge, we should say what are the relievers, what will be the controller. And if the patient is admitted in PICU, definitely we need to start the controller. Or if the patient is already on controller, we need to step up the dose for 2 to 4 weeks. Prednisolone should be continued for 5 days, and the follow-up is extremely important. So, in short, the take home message for the today's session, as in general, asthma can begin at any age. Not all under 5 years develop asthma in future. Episodic viral Vs below 5 years respond very poorly to conventional asthma management. Modified asthma predictive index can help to predict asthma in future. Largely, asthma remains a clinical diagnosis, so history taking is must, and several investigations are supportive. Inhaled corticosteroids are the mainstay in managing pediatric asthma. Comorbid conditions need to be addressed. Management of asthma is a teamwork where the parental patient education, counseling, and the written asthma action plan plays a vital role. With appropriate asthma management, acute exacerbations can be prevented. So really, I'm very thankful to everyone, and information is the key. So we should use our words appropriately, and I hope with everyone together, we can achieve the better asthma control in all our patients. Thank you very much. Thank you, everyone.
Thank you, Dr. Smita. It was indeed a Herculean task to complete all this well in time. I welcome Dr. Sagar sir for his expert comments. Sir, just there is a lot of confusion about the use of nebulization. The delegates are asking whether we should not be using it even in an acute attack. Even in the first, there is one more question stating that first episode of a wheeze, should we be using a nebulizer or an inhaler? Sir, maybe you could just throw light on these points.
So, very nicely presented, madam. You have done excellent job in the 8 to 10 slides. Thank you. And the most important thing is I'll cover. So there are three different subtypes in this question. First is first attack. Suppose there is a first attack, and suppose somebody is staying away from hospital, but as already in previous three talks we have mentioned that nowadays everybody has got nebulizer at home. So in that dire situation, I would definitely suggest to give nebulization till you see your doctor. But once the diagnosis has been done, and once they have the inhaler, there is no question about a nebulizer at home, because it's a dangerous, because nebulizer, the flow is high, the drug is more, and the most important is when you're supposed to give that nebulizer for 10 to 15 minutes, the hypoxia chances are more. So that is the most important reason that we should never advocate giving nebulizer at home, because it can cause reversible hypoxia once you finish the nebulizer. So even in hospital, the nebulizer, if you're giving nebulization for any patient, it has to be given with the oxygen. It should not be given just by electrical machine support. It should be oxygen driven, not the electricity driven. That is the most important point, as madam has said already. If that message has gone viral, I think that will be a great achievement for us. Second, but if there is nothing in first, you have to. Then even in a very acute situation, rightly said in the last talk, that till you meet your doctor, you can continue with the SABA drug till you see your doctor. Every 20 minutes, you can give 4 to 6 puffs also till you see the doctor. Okay, because it takes hardly 1 or 2 minutes to give through the inhaler, even in your OPD. So what I do in my OPD, I have 4 devices. Suppose somebody comes and in severe condition, then these 4 devices are clean usually. And so immediately I tell them to start with this if there is an improvement, and then they are also very happy. It's very convenient for them. And only thing is, when a child is very agitated, not ready to accept, very much hypoxia, then I have oxygen even in my OPD. In that situation, there is a there is a use of nebulizer, but otherwise MDI with spacer is the best, even in acute moderate to severe. Mild to no question, we have to use it, but in moderate to severe condition also, till you see your doctor or till you go to your nearby emergency room, the message is to give with your MDI devices, the SABA, or adolescent, you have to give your MART therapy, whichever medicine given to your doctor. That is the most important. Once you see the child is into moderate to severe, he's going into hypoxic state, the most important drug which has to be given is oral steroid. And because once he goes into too much hypoxia, then IV steroid is the only availability. But if you give that steroid, it is going to take at least 4 hours to act, and then that golden period we are going to miss. The most important message, third message is, try and give continuous nebulization once you admit the patient with the help of oxygen. Without oxygen, no nebulization, because that hypoxia will trigger more of bronchospasm also. And if you continue to give nebulization as salbutamol or short acting beta agonist, the chances of getting intubated or use of NIV are very I mean they goes down tremendously. And these children like asthma or bronchiolitis, if you intubate, it's very difficult because we have to manage with volume control, and there are so many things to be how to adjust, eye time and all these things. So it is very difficult for these kids to manage on ventilator because of paucity. Some places there will be bronchospasm, because that is the reason we get polyphonic wheeze. Some places you will have no spasm at all in the lung, so that going to cause a lot of barotrauma or volume trauma also. So the important message is continuous nebulization when is there when they are in IPCU and in a severe category of acute exacerbation. But MDI with spacer is the devices of choice in mild, moderate, even in severe also, in initial period.
Thank you, sir. I think you have already answered this. MART therapy, how often we give during acute attack, or should we shift to SABA?
So again, these depend on age. Previously, it has been mentioned. So MART therapy is basically for adolescent because they don't like two devices. Even one is also difficult for them to continue, and that is the reason this therapy has come. So best thing is MART therapy. So the dose is because it contains 6 microgram of LABA, that is long acting beta agonist. So how much to give is again question, because of there is no what you say a complete evidence, but we can give up to 72 microgram per day. So that is almost I would say 12 pumps. Yes, that we can give it per day. So that is what the recent evidence. But so maybe 3 times or 4 times a day. But most important is recognition. So I spend maximum time in recognition. So I give them once whenever there is a daytime symptoms or nighttime symptom, you start thrice a day. When the symptoms are increasing, signs of early breathlessness, you go every 4 hourly, and very severe till you see your doctor 20 minutes, like that you give that. That's what the asthma action plan is, very very important. When you give it to them, that's very easy and convenient for them, and they are very
monitoring.
Peak flow meter.
And monitoring with peak flow meter is very essential.
But
But
less than 80% mild, and 60 to 80% how many dose, and less than 60% they need to see their doctor. That's what even Malvika mentioned in the asthma action plan, and Dr. Smita mentioned that asthma action plan. Dr. Sagar is reinstating that these are important, that your patient should know what to do when. This is what Dr. Smita mentioned by information is key, that you have to tell them this is it. So monitoring with peak flow and also checking the oxygen saturation. all of you are a little shaken by it, that can just the MDR and spacer happen? And here is Dr. Sagar saying, I do it in my clinic. I do it too. In the first episode, when a doctor said that, do we need to do it with an if you use a spacer and a mask in an under 5 and the child has settled, that parents will know that this is the magic and not your nebulizer box. The moment he feels this is the magic, he was going to buy that because it's not so expensive. So as all of us say, that's probably the lesson, isn't it, Dr. Sagar and
Yeah.
Smita?
Just one more thing. In fact, sometimes I've noted the child themselves tell, even a under 5 will tell he feels good, and they actually bring the device each time they fall ill. They'll come with the device themselves. मुझे ये दे दो. Smart children are, they go even up to that extent nowadays.
So smart children are because they are taught the smart thing. If you give them the nebulization, then similar pe. So it depends. I mean, the smart child is a smart doctor, I would say.
So very important message is because this year the Gina has said education empowerment. So I think asthma only 3-4 drugs are there. Everybody can treat. The most important thing is how you educate the parents, how you inform, how you inform to the parents as well as the relatives who are going to come to you. If you spend time for that particular counseling, I think you have done your 50%, more than 50%. I think more than 90% achieved because drugs are hardly there is flutic acid is not available in India. So you don't have to remember different drugs, dosage. It's very easy. And there are flow chart given by Gina. So it's very easy. So most important is spend time with the patient once, twice. Then they are very, very comfortable. Try understand their questions and what are their problems facing while doing this therapy. I think then we can achieve the asthma control in India.
There is a last question by Dr. Vaishali Gandhi. Is levosalbutamol allowed below 6 years?
Yes, of course. So levosalbutamol or salbutamol both are equal. You can use anything. There is nothing like levosalbutamol is superior to us. Only salbutamol. You can use anything. So you can use more than 6 months. You can use any child. Because less than 6 months, there are so many other factors which contribute to wheezing, and we need to find out if are we missing anything. Because less than 6 months asthma or wheezing means we have to find out any anatomical causes also. So that is the reason we don't use it.
If there is a good response to the salbutamol, then that could be like the first episode. So
yes,
you're good to give it.
Thank you so much, Barnali ma'am and Sagar sir. So as we come to the end of this wonderful session, it's my privilege to deliver the vote of thanks on behalf of the organizing team. I would like to thank Dr. Ram Gopal sir, our President Maha-AP, Dr. Amol Pawar sir, Secretary General Maha-AP, Dr. Bhavesh Mithya sir, our scientific chairperson who has given us these amazing topics each month, different topics. Dr. Amruta Bhaviskar, Dr. Manjusha Sherkar Madam, our chairperson, Women's Committee, Dr. Amruta Bhaviskar, co-chair, convener, Women's Committee. Thank you so much, Barnali ma'am and Sagar sir. You have been really excellent experts, no words. And our speakers for today who are experts by themselves, Dr. Vikram, Dr. Sainath Pawar, Dr. Smita madam, Dr. Malvika madam, and Dr. RP. And not to forget my co-moderator today, Dr. Vrishali Sarode. Thank you so much. And I'm sure we have really given clear take-home messages from today's talk. So, and good night.
Thanks, Grivita, and thanks, Pallavi ma'am, also for your excellent digital support. Thank you. Thank you, Barnali ma'am, Sagar sir. Thank you so much.
Thank you. Thank you.
Thank you.